Hello, everyone, and welcome to this session on trying to internalize the emergency physician and intensivist in the same shoes. Very excited to be joining the conference of the Association of Anesthesiologists of Uganda. And for those of you that perhaps don't know my history with anesthesia, if you took a random walk in Mulago, perhaps 2-3 years ago, many people would have called me an anesthesiologist because I think I belong. So I was not surprised when I was requested to give this talk. In many countries, unfortunately, there's a lot of tribalism between these two incredibly special and amazing specialties. And I'm glad that in Uganda, we are at a stage where we appreciate one another and we try to build and work with one another to offer acute care for Ugandans. Dr. Annet Alenyo Ngabirano, I'm an emergency physician with a case of intensivism. Did I say it right? Intensivistism. There you go. So as an emergency physician, of course, a lot of what we do is acute care and resuscitation. And if you are working in critical care or emergency medicine, especially if you've recently gone through a training program, the mcrit.org website shouldn't be new to you. It's something we've often referred to, because especially for me as an emergency physician, it is written by an emergency physician who, like me, loves critical care. And there's a certain definitions that are evolving over time. Some of these words are not things that we interacted with 2-3 years ago. Of course, a resuscitationist is a clinician who can be from any specialty in medicine, but is committed to optimal care of the critically ill patient during the initial hours of their care. And I'm hoping many of us attending this conference either call ourselves resuscitationists or at least try to be resuscitationists. There is also in the US people who are emergency medicine critical care. So the US has a very interesting training structure where people can be dual or probably even triple trained, but they have a subspecialty of emergency medicine dealing with critical illness, both in the ED and in other parts of the hospital. But the one I would like to pick us out most is the emergency an emergency physician who has completed their MED or residency in emergency medicine, and thereafter goes ahead to do further subspecialty training in critical care. It is something that I hope we as emergency physicians start thinking about and start cultivating. So what I'm going to take you through, and perhaps it's to compare the two brains of this specialty. On the one side, the emergency physician, on the other side, the intensivist anesthesiologist, and try to see if perhaps we can fit in the same shoes. So let's start with the emergency medicine mindset. So according to the American College of Emergency Physicians, what we as emergency physicians deal with is the initial evaluation, diagnosis, treatment, and disposition of any patient requiring expeditious medical, surgical, or psychiatric care. And this also includes things like pediatrics and obstetrics, gynecology. So where do we work? The picture on the top is your typical emergency department in many hospitals in Africa, even in Uganda, and a crowded room, not very well equipped, lots of patients, lots of attendants, doctors, nurses, lab techs coming to take off samples, radiographers, radiologists. It's quite a pot of activity happening there. And despite what any emergency physician will tell you, this place is heavy, it's full, we actually somehow enjoy creating order out of that seeming chaos. It is a special skill for us. The picture at the bottom is an ideal resuscitation area, complete with a ventilator, ultrasound scan, a crash cart, a beautiful bed, and enough space for a team to do a full-on resuscitation. So a typical emergency department that is well designed with proper flow will have a number of silos of care, and this may be, pediatric versus adult, and then in either of those you'll have areas for managing various acuity or various patient acuity. And that may range from a green patient who is really your third priority, to a yellow patient who is your second priority, and to a red patient who is your first priority patient. And I'm using a standard triage that we're using in Uganda, the Uganda triage and treatment algorithm that is adapted from the WHO interagency integrated triage score. So what else do we do? So our doors, these doors that I showed you, are open to anyone, any time of the day and anywhere really. So 24 hours a day, 7 days a week, throughout the year, the doors of the emergency department should be open. If you go to an emergency department and you find the doors closed, there's a big problem, or it is not an emergency department. An emergency department should always be open for business. And that means that in addition to this, you must have staff always available on the floor to manage patients. The other thing in our minds, of course, a big thing is resuscitation. And we, different schools of thought will give you their different ways and checklists and tips and guidelines. And I love the 7 tips on resuscitation that I got again from one of my other favorite websites. It's, as an emergency physician, we have a safety net. Monitor oxygen IV line, and that is a standard dogma for us. Any acute patient you see, you must initially have that at the back of your mind. We also run towards sick patients. We don't run away from trouble. Every time there's a sick patient, that it gravitates us, and that is really part of our design. We also don't just follow algorithms, and I know a lot of emergency care is designed around algorithms, but as you mature in the specialty, you need to learn when you should stray from the algorithm a bit, think outside the box, especially in our setting where algorithms don't always easily translate at the bedside because of different things. You're alone, you don't have ABCD, the algorithm asks you to check blood gas, and well, you don't have a blood gas. So it's very important for us to learn to tweak these algorithms to suit us. Of course, the other thing is know where equipment is located. You cannot start running around looking for equipment in the middle of a resuscitation. We train hard. We really train hard. Simulation, on the job, we work hard, we train hard. And, a few things. If you're running the resuscitation, do not be the one doing the procedures. And another thing, of course, the most important heartbeat in a resuscitation is actually the team leaders. If your team leader gets tachycardic, the entire resuscitation is completely a mess. And when asking people to perform tasks, task a specific person, not the general room. So those are our resuscitation tips and things we try to exemplify as we work and manage patients. The other thing, of course, is that we manage undifferentiated patients. Patients walk in, and for many people admitting patients, physicians, surgeons, pediatricians, down the line, you're receiving a patient who has been worked out. But in the emergency department, it is abdominal pain. It could be medical, it could be surgical, it could be obstetric. The onus is on you to find out what type of pain it is, what is most likely causing this complaint in this patient. It's something that we really love doing. Of course, the other thing for us in our brain is always avoiding cognitive errors and anchoring bias and availability bias. It's very, very, very easy for an emergency physician working in the setting they work in, the workload they do, it's probably 3 a.m. for you to anchor yourself to a specific case. We often encourage in our mindset as emergency physicians is always have a differential diagnosis, even if something is straightforward. Ask yourself, what are the 2 or 3 worst things that could be? Reevaluate your patient, reevaluate, re-image, and vital signs and lab tests before deciding on a disposition. Because once you put a patient on a certain path, getting them off that path within the hospital can be incredibly challenging. So be as open as you can, and also and I would like to go back to the second point, thinking of the worst thing. What could be the worst thing that this abdominal pain could be, and you eliminate it, and unconsciously it also seeps into our life, even beyond medicine. Even at home, when I'm seated and there's a problem, I'm often going to start with this. And people are often like, why do you have to think about that? I'm like, well, that's the worst thing that can happen. So let's eliminate it, and then we can deal with whatever else it can be. And it's a strong part of our training. We shouldn't miss things that kill patients. The other thing for us in our mindset as emergency physicians is always listen to nurses. You see, unlike doctors, and this goes across specialties, unlike doctors who get a snapshot. So when a doctor sees a patient, it's often that snapshot of the time you've assessed and assessed and managed your patient. The nurses, however, have a video of the patient. You have one clip of a picture. They have a video of the patient. They've been at the bedside, they've done bed pans, they've seen which visitors come in, they've seen how this patient has behaved with no one at the bedside. They have an actual video of this patient. And therefore, if they tell you there's something wrong, or if they tell you there's something right, you need to listen. The other big thing about us is communication and compassion. In my work, and I've worked with so many people, that times I've been upset about anything or been very firm or had a disagreement with anyone at all. 99% of the time, it has been because of a patient, because I have felt that we have not done right by the patient. And we need to see patients as people, as human beings who have a disease, not the disease. And this is something that resonates a lot with us in emergency care, because we see the best and also the worst of humanity in the setting that we work in. We see people coming in, we see even non-medical emergencies, but we have to respond. We have to be compassionate. We also have to learn how to communicate well with patients and their family in a way that draws them to us and allows them to open up to us more. And one of my favorites, playing Tetris with time. You have to be some sort of octopus to do some of the things that we have to do working in an emergency department. The good thing about this, I know it's a bit scary, but the good thing is that the more you do it, the better you get. And you're slowly able to tease out what the important things are about different patients. And not something I'd encourage you to force in the beginning of your career. It's something that comes as you see many patients and that's going to be a very simple thing to sort. And then some patients may appear simple, but in the end, they're actually very complicated. And finally, hard work. If you are thinking of a career in emergency medicine, you must work hard. That's it. There's no room, there's no space in an emergency department for laziness. It's always on your feet, thinking, making decisions, planning, procedures. It's very intense, and therefore you have to be willing to work. And the beauty again of this is the more you work, the better you get. So I'm going to tell you a story before we cross, and I've just given you a snapshot of what the mindset of an emergency physician. So I'm going to tell you a story before we cross into the mindset of an intensivist that taught me a lesson and re-emphasized to me as an individual that, well, I'm an emergency physician. So in my final year of training, of residency, in my fourth year, I was doing my anesthesia rotation in a hospital in Cape Town, and we had this incredibly challenging case. So a 14-year-old comes in, clinically acute appendicitis, and there was no two ways about that. So the surgical registrar, in South Africa, they call them registrars or residents, or the SHO. So the surgery SHO decided, well, let's go to theater. I assessed this boy, and he was getting septic. He was dehydrated. It was one of those patients you really need to resuscitate even way before you give your anesthesia. So it's a Wednesday evening. I'm on call. He's on call. So the emergency medicine SHO and the surgery SHO. So I resuscitate this guy from the emergency department, wheel him to theater, and we have an operation that took 6.5 hours. So we started around 6 o'clock. So I am pumping fluids exactly like an octopus and relying on my emergency medicine skills, pumping fluids, checking antibiotics, pain, chatting. I did like probably four anesthetic chats for this young man. And the surgery went well. Of course, the SHO started laparoscopically, and we ended up in an open surgery, despite our initial discussion of why don't you just open straight away. But anyways, at the end, after he's finished the operation, I'm extubating this guy, and he's a big, strong 14-year-old, and he takes a deep breath, and as I'm pulling out the tube, his breathing changes. It becomes a bit more rapid. So I think, okay, that should be fine. Suction quickly, suction as I take out the tube, check my monitors, cycle the blood pressure, he's stable. I'm like, all right. So I'm just finalizing my last few notes, and I see, I don't like this breathing. And we just moved him off the theater table onto the trolley to take him to the post anesthesia room. And it's just me, the surgery SHO, and the nurse. And I tell the nurse, I'm not happy with this. So I auscultate his chest, and it is completely wet. In the next 5 minutes, I can literally hear the wetness without even a stethoscope. He's starting to drop SATs. I'm like, okay, this is pulmonary edema. The surgeon is like, no, Annet, you didn't give morphine. This boy has aspirated. And I'm like, no, my friend, I have seen pulmonary edema. This is pulmonary edema. I don't understand why this is pulmonary edema or what has caused it, but clinically, this is pulmonary edema. So I start thinking, I'm an anesthesiologist I'm in theater, I'm in the shoes of an anesthesiologist. Look at that picture. This is the typical anesthesia, Musirise look. So I'm in my nice scrubs, I have all my drugs. I'm like, no. So I look at my card, and I'm in this environment that I don't routinely work, but I'm like, what do I do? So I call the consultant, and he tells me, Annet, I'm not with the patient, you're with the patient. What do you think you should do? I said, well, I'm going to reintubate him. He says, okay, that's your patient. So I get off, and this surgery SHO is just raining in my ears. He's like, but you anesthesia, and he kept calling me anesthesia. I think I got to a point, I said, no. I think that's the problem. I'm in the wrong shoes. He's looking at me as anesthesia. I'm trying to think like an anesthesiologist in a crisis. And I am in my 4th year. I'm just about to graduate and as an emergency physician. So I said, no, I'm an emergency physician. I am going to picture myself in the ED. This guy has been brought in the ED, and I'm going to sort this as an emergency physician. And I guarantee you, once I put myself in my real shoes, that's it. In 5 minutes, this boy was intubated. I'd put him back on the ventilator, and I was calling ICU. I'm bringing this boy, we'll ventilate him overnight and see how he does in the morning. So this is 3 a.m. Reintubate this guy, take him to ICU. I actually clocked him because now I reached ICU and I was comfortable in my ICU shoes. So I got the ICU notes. There was no doctor on at the time. I clocked him, admitted him, left him on his treatment. Next morning, I called to check on him. The guys are like, oh, his lungs are cleared. We're actually preparing to extubate him. In whose shoes? So let's look at the critical care mindset. Again, so actually, it is quite similar. So look at the critical care. So the critical care or the intensivist focuses upon a care of very sick patients needing 24-hour supervision by a team of healthcare professionals. So that means constant monitoring, really, a patient who needs someone at their bedside. And that means a very sick patient. So where do we work as intensivists? So I told you, I moved this guy from being an anesthesiologist to transitioning back into my emergency physician shoes. And when I went to ICU, I clocked in as an intensivist. And where do we work as intensivists? So we work in the ICU. And look at that 24-hour monitoring, what it requires. A lot of bed space, incredibly big bed. You don't need have this type of bed in the ED. You have a bed that has multiple functions and that you can position your patient, weigh your patient, and do a lot of things with the bed. You have bedside care, nursing care, you have your intensivist making decisions of care, you have your monitors, you have your crash cart next to the patient. It is quite a lot, but it is what it is. So what else about the ICU? So the ICU also should admit anyone that requires ICU care any time of the day. So it is also a 24/7, 365, 366 service. Anywhere doesn't apply because, well, it is an ICU, it is not anywhere. And when it comes to resuscitation, guys, it is the same approach. You need a safety net, you run towards sick patients. The sickest patient in the hospital, the first thing everyone will be like, call ICU. Don't just follow algorithms. Treat the patient. Physiology. What is the physiology telling you? What is the pathology telling you? Respond to that. Know where your equipment is located. In the ICU, you must know where everything is. You should also train hard. ICU intensivists train hard. If you're running any resuscitation in the ICU, again, same concept. Step aside as the team leader and run the resuscitation. When asking people to perform tasks, again, task specific. So our resuscitation attitude and our mindset in resuscitation is the same. Errors and bias, same thing. Anchoring bias, and even especially in an ICU, you must literally unpack that body and view it as you would in a physiology lab. And so you must always have a list of problems. What is wrong with this patient? And sometimes they're not even actual diagnosis, they are problems to be fixed. And what are the worst things with your patients? What should you foresee that could be the worst thing that could happen and kill your patient? And reevaluating, I don't need to re-echo this, even in you must always be on top of what's happening with your patient. And again, please, ICU nurses, same to the ED nurses, the nurse knows the patient video. You usually get a snapshot. So listen to your nurses. Again, opportunity is missed by most people because it is dressed in overalls and looks like work. ICU intensive care is heavy work. You have to be there, you have to show up, you have to work hard. Same thing, same attitude. So back to those shoes. So are these really the same shoes? When you look at the skill set, similar skill set. When you look at the attitude, I've taken you through the mindset. Similar. When you look at where we work, yes, we have our resuscitation area, there's ICU, we have that, chaotic emergency sections of the emergency department, but we generally work in places that treat acutely unwell patients that need to be monitored, that need rapid decisions, that need a lot of procedures and need a lot of management and teamwork. As far as listening to nurses, emergency physician, intensivist, well, any doctor really, you must listen to your nurse. Working hard and working smart, same shoes. So, colleagues, it's really we are same but different, like they say in Uganda. These guys are same but different. Well, we have similar skill sets. We work in environments that demand similar things from us, that demand certain levels of knowledge, certain attitudes, certain communication skills, that demand a certain level of being there for patients as emergency physicians, as intensivists. So we agreed that an intensivist is a post-specialty care. In Uganda, a lot of critical care, intensive care medicine is provided by anesthesiologists because of their training and the skill set it provides. Emergency medicine is a new specialty, but the training in emergency medicine also provides a similar skill set. And so my conclusion on this is that in our low resource setting, where subspecialty training in critical care is nearly non-existent, postgraduate trained emergency physicians are actually an important resource in filling the critical care gap in the country. I've done it. I have worked in an ICU. I've supported in ICU when they needed more people. Even in COVID, I've squeezed very painfully some hours to support in the ICU, and the team has welcomed me because they know that my training provides me the skill set to work in an ICU. So my friends, anesthesiologists and emergency physicians, you are same, but different. Thank you very much. I'll take any questions.